Okay, it looks like all the slides are resized and we're ready to go. This is the first time I've had an opportunity to introduce Dr. Graham. She's also a longtime friend and colleague from Texas Tech University, the same institution that I'm from. She's originally from the northeastern United States and received a bachelor's degree and a master's of public health from Cornell University, which is a very well-known university in the U.S. And then she received her MD degree from another extremely well-known university, Duke University in North Carolina. She's a pathologist, and she received her pathology training at the University of Kentucky, where she did internship, residency, and fellowships. She holds licenses in pathology in the states of Texas and New York. She is board certified in anatomic and clinical pathology. At our institution, she is not only a pathologist, but she is very active in teaching medical students and received quite a large number of teaching awards. So with those introductions, Dr. Suzanne Graham.
I will try, number one, to keep the microphone so it will be on. Number two, if I do talk too quickly, somebody raise their hand and I will slow down. We have resized these slides, so hopefully everyone can see. In doing so, some of the title slides, I'll tell you about how I'm going to do this in a second. The emphasis, the highlights have been taken out, the color, because the colors didn't show up well, but they will be in the stuff that you have on the disc, okay, which is the sort of the smaller print version of this, all right? Let's see here. General pathology. Some people say, well, what do you know you need to know about pathology? Pathology is not a slide or the study of a slide. It is the study of disease. It is everything. So we cross over, and I've been through several of the sessions, and I will talk about diseases that other people have talked about. Why? Because they're good for questions. They go back to genetics, they go back to basics. They have, really good methods that we can ask and plumb your brain, all right? Other things like breast cancers. We don't get a lot of questions on breast cancers. It's hard to ask a good question about a breast cancer, except to talk about the mechanisms. And that's happening to pathology. It's no longer just slides and what tests. It's what's the underground genetics behind it. So that's where I'm going to try to emphasize what you're going to have to go back to and why you need to remember that stuff from first year, all right? Because you're going to see it again and again, all right? And we'll go through questions with audience response, and that has been working well, did you think? Okay, and be brave and answer, even if you're wrong. It's anonymous, and very important. And one thing I will use in here, as I go through, hopefully I will get through what I'm planning to talk about, but there will be some more slides in the presentation. That will be some things that I knew I couldn't get to that I thought might be helpful. But there's a way, when Dr. Strauss was talking about learning all of those bugs, I could practically hear you groan, because he said learn these bugs and those bugs. And he's right, but how do you put them together? How do you remember them? And every one of yours minds works differently. The way you hang knowledge on the tree is different than your friend. I hang them in grids. I compare these diseases with the things I need to know about the diseases and say, how is this disease different? How are these diseases alike? That's the way I've always studied. So as I'm going through, you will have to know much more than I talk about, but I will show you some of my grids, and hopefully they will help you put pathology together, okay? All right. Importantly, too, as you go through these questions, and I am not the only one who has said this, every time you get a question. How many of you are using review books, the BRS series or one of the series from the United States, for the USMLE review books? How many of you? Any? There are many, and there are many different ones, okay? And many of them are very good. Pick one series. They all say the same thing. Don't take 7 books on one subject. They will contradict each other. They can't help it. Pick one that you like and stick with it, because if you brainstorm, if you just take every question and work it and figure out why did they ask me that? Where do I have to go? What do I have to know to be able to get this right? If you use one book, you will do as well as someone who uses another book who does the same thing, okay? It will save you time. All right, and just never memorize the right answer. You've been told that 1,000 times. Believe it. All right. Many sources, and you can't read this well, okay? But there is something called WebPath, and it's on the web. The web is marvelous. If you want a picture of something, go look for it. But WebPath was originally based out of the University of Utah. But if you go to Google and put WebPath, it will take you to one of many websites. It is a very good source of pictures and questions, and it's always updated. There are many more. There are many good books, and I get no money from any of them. So go to the one that you like and pick one. Okay. Let's talk about general pathology. General pathology is the boring part of pathology. It's the what do I need to know that I apply to all the organ systems. And it is very boring to learn because it's a lot of molecular biology. And as I go through, and I'll show you a list of material, and you'll go, is she going to just talk that? I'm not. I'm going to pick just a few things on that slide that will be emphasized in your handouts about what I think, if you know these cytokines, then you would recognize them as being related to a macrophage, because there's so much. Do any of you read Robbins? Okay, Do you know, I mean, if you read Robbins, there's so much data, I can't remember it, and I'm learning it the week before I teach it to you. So this is from somebody who did not learn this in medical school. I'm learning it with you too. So I'm trying to tell you what's the high points, okay? We'll talk just about the injury and how I'm going to go about that. The injury is everything that can hurt you. All of Dr. Strauss's bugs, a knife, okay, an oncogene that's causing cancer, anything that can hurt you. You're the host. So everything is about learning about all the injuries and how you respond to that, the inflammatory response. And if you are a strong host, you will fight them off. If you're a weak host, if you're young, if you're old, if you're immunocompromised, all the rules are off. We teach you the main rules, okay? Learn those. Don't worry about the little details and the exceptions. I bet there are some of you in here who worry about the details, right? It will get you in trouble, okay? So try to pick the rules and worry about the 5% that doesn't follow it later when you become an intern, all right? We'll talk about the cell types you need to be able to recognize, acute versus chronic inflammation. I will just highlight some of the things on hypersensitivity and immunity, because we'll talk about those in some organ systems. It will be a repeat of what Dr. Strauss, so I will just quickly highlight a few things. And we'll talk about how that's manifested clinically a little bit, because the clinicians have already talked a lot about that, and we'll continue, and we'll talk about neoplasia again. Up at the top is injury, anything that can hurt you. And your response to that injury is all about this. That's all about pathology and how you respond to that. Now, if you are a good, strong host and you have a minor injury, then you may be able to adapt to it and just get a bigger heart or a stronger muscle all right? But in most cases, there's enough injury for some tissue to die. And if it dies in little bits, one at a time, then you can have apoptosis. And we'll talk about apoptosis, because apoptosis is not always abnormal. Or if you have a big injury or you're a weak host, you get necrosis. Then you get acute inflammation. And if you can wipe out the bug, okay, or stop the injury, then it stops at acute and you resolve. Very little scar left, everything regenerates, you're fine. But in most cases, injury continues. You don't respond well. Then you get chronic inflammation, all kinds of patterns, very complex. This is where autoimmune diseases are, hypersensitivity, all kinds. We will only touch on it, very complex. You'll have to learn to pick out the details. We'll talk about that briefly. Then, once the injury goes away, once you've walled it off, then you regenerate when you can, or scar down, and then hopefully you're healed. This is all of disease, all right? Now, apoptosis, 10 years ago was one paragraph in Robbins. Now it is chapters in Robbins. And that is good for you, because when you read about it and they say that they're not sure about this and they're not sure about that, they can't ask a test question on it, can they? Okay, so remember the highlights are important because that's what they figure everybody agrees on. So with apoptosis, lots of things that can go wrong. Number one, it can be normal. It's the normal way you lose cells in hormone depletion, in changes of hormones. So apoptosis is not always abnormal. But and it's initiated by death receptors, by mitochondria, by cytotoxic T cells, which we'll get to in a minute. And its death is execution, as it were. Well, it's death, actually. This is execution, is by something called the caspase cascade. So CD8 T cells are very much involved, as well as macrophages. And macrophages are the king of inflammation. They orchestrate everything, all right? Never forget the macrophage. The results in apoptosis with a little injury or in certain patterns of injury is you get just a few cells dead. Not even enough to stir up inflammation. No leaky vessels, no nothing, except maybe a few T lymphocytes, maybe a few macrophages. And again, it's not always abnormal. Now, if you have, and this is the classic example, I will show you some pictures, all right? So this is all of the pictures, unless I tell you, are routine H and E slides, hematoxylin and eosin slides, and you're used to those, right? Okay. So this is liver. Can't tell it's liver, really, but all of these are alive. This is dead. This is the old-fashioned Councilman body. That's an apoptotic, one dead cell in the liver, viral, characteristic of viral hepatitis. So apoptosis is characteristic of viral hepatitis. So apoptosis is characteristic of little injuries and certain injuries like virus. And that happens in a lot of injurious patterns. Certain types of injury produce certain kinds of response. Viruses, apoptosis, all right? And so this little bitty red dead cell, and in a second it'll disappear. Here's a lymphocyte. That's it. Nobody else is there for the funeral, all right? Now, if there's too little of it because of gene mutations, you can get cancer or overgrowth of the lymphoid system and autoimmune diseases. Very complex, but all tied together by too little apoptosis. This is a big thing in cancer. Too much of it, you get too much death, and something I will not talk about today, the neurodegenerative diseases. They like to ask questions about this, not because you will ever see them unless you happen to have a family related to this, is that it's a great model to study too much apoptosis. Now, interestingly, when we talk about necrosis, which is big, bad necrosis, big, bad death, it's in, for instance, myocardial infarctions. We'll talk about coagulative necrosis, large areas of essentially mummified tissue. But it turns out that when you get a little ischemic necrosis, a little loss of oxygen delivery, then you can also get some apoptosis, and you'll see more of that in the heart. So little injuries that normally produce big characteristic areas of necrosis can produce apoptosis too. Now, is this important right now? We may find out later, okay? Whether you can ask a question about it, I don't know. But viral infections are always very important with this. Now, this is in contrast to necrosis, which is lots of death and all kinds of classic acute and chronic inflammation. A diabetic foot. Most of you have probably seen dry gangrene. Gangrene is lots of necrosis, and when it's coagulative, it's like a mummy. It's dry because it's not infected. And it'll stay there. It'll be a dead toe for a while. Eventually, it'll fall off. Eventually, the heart will go away, but for a while, it'll just be like a tombstone. That's coagulative necrosis. That's characteristic of ischemic necrosis. Diabetes, vessel disease. You know that, okay? If you have infection, the neutrophils bring all kinds of enzymes. You eat it up, liquefactive. It becomes liquid right away. Liquefactive necrosis. Have you heard that term? All right. So in this case, this is a diabetic infected foot. So ischemic necrosis now infected, liquefactive. Okay, all kinds of reaction. Now acute inflammation, big deal. Lots of vessel leakage, swelling, edema. Neutrophils and macrophages are kings. These big cells are emphasized in your thing. I had to take them out. So they used to be blue, but it wouldn't have shown. Okay? Neutrophils and then interferon, IFN gamma. Big things with macrophages. Always tie these two together. Then tumor necrosis factor, TNF alpha, interleukin-1, nitric oxide. Remember these guys. If you see those, you know you're in inflammation. In acute and or ongoing chronic inflammation. Lots of other cytokines, chemokines, all kinds of things. These are the biggies, all right? These are the cells in acute. Chronic inflammation. You are going to have to study this on your own for peculiarities. I'm just touching the highlights. We'll talk about this. Lots of macrophages and T cells involved in this. All kinds of patterns for this. We'll come up on a few in a minute. The big one that people get confused about is the granuloma, the delayed hypersensitivity one. Again, remember, it's macrophages are king. When you want to heal, you need fibrosis, you need bloods to feed it. So you end up with fibrovascular repair or granulation tissue, and that's all granulation tissue is. All right? And this is going to all, again, growth factors, GF, growth factors, okay, bringing in fibroblasts, angiogenesis with VEGF. Everybody loves VEGF, okay? And this is all very important, not only here in regular repair, but also probably in tumor analysis. Cells of interest. Be able to recognize just common cells. A lot of my medical students cannot recognize a neutrophil. Okay? Do not be like them. They learn. All right? Lymphocytes, segmented or polymorphonucleocytes. That's why people call them PMNs. Who wants to say polymorphonucleocytes? All right? Some of my students call them newts. All right, but they're multilobated cells, and compare the size. If you don't know what they are, here is a 7 to 10 micron red cell. So these are a bit bigger, multilobated, separate little lobes. PMN, know what it is, be able to define it from a lymphocyte. Here is a band, which is an immature, unsegmented neutrophil. All right, I'm not sure what this was trying to be. All right. I wanted to make it into an eosinophil, but it's not. I think it's a broken segment. Don't worry about this one. And this you never see out there usually. That's a basophil. All right. And here is a monocyte. All right. So just know those cells. Immunity, we've been through this before. Innate immunity, natural killer cells. Adaptive immunity, which is where you spend most of your time, has to do with lymphocytes and macrophages working together with antibodies, all right, to adapt to antigens you deal with all your life. In all of this hodgepodge of immunity and hypersensitivity, try to begin to list cells or diseases that are characteristic of that particular entity, and that will help you remember them or deal with them in an exam. All right. It depends on the major histocompatibility 1 or 2 antigen, depending on which cell attaches, and what do you call it, cell-mediated immunity. CD8 cells recognize major histocompatibility 1, and they're very characteristic of virus infection. These are the guys that we saw with that Conselman body. So cytotoxic T cells recognize major histocompatibility 1, and part of that has to do with where the organism or problem is in the cytoplasm or in the vesicle. You don't have to remember down to that area, but you can remember that the reason that certain diseases are associated with different kinds of response has to do with where the antigen is, where the problem is, and that will be clarified later. Okay. One that commonly comes up are CD4 helper cells, which deal with major histocompatibility 2. One of them, subtype, the type 1 helper cells, are mostly related to macrophages and are clearly related to the response to tuberculosis, as well as to opsonization elsewhere. Th2 is a different system, again, still CD4 related again, primarily as far as our model goes with asthma, because eosinophils are very much involved in this, and this all has to do with the interleukins that stimulate and drive this system. So just learn that there are certain interleukins and cytokines associated with certain cells and certain responses, specifically Th1, TB, Th2, IgE, asthma. And we'll see this again. You'll say, I'll forget this. But you're not, you will until you use it, until you practice it a bit. Humoral, that's cell-related immunity, T cells, macrophages. And helped in this is very complex, this is never all or one, are humoral immunity with lots of B cells, antibodies, you know all about that. Okay. Hypersensitivity, remember some of the diseases associated with that. IgE, asthma, anaphylaxis, allergies, parasites. Parasites aren't up there. Okay? If you know that, you'll know everything about IgE. And 1. 2 covers lots of things, that opsonization of bugs, transfusion reactions, but you'll see it mostly in autoimmune hemolytic anemias and in Goodpasture syndrome. Now, Goodpasture syndrome you hadn't heard about. It's a very popular disease to ask a question about in the United States. We'll hit that a bit again in kidney. But it's a disease that you end up with an antibody against an antigen in the matrix of the basement membrane of both the kidney and the lung. And you end up, therefore, with symptoms in both those places. So how might somebody who has attacking the basement membranes of their blood vessels in their lungs present? What would happen? They would cough up blood, okay? And they would pee out blood because they have leaky blood vessels. So the mechanism will tell you how they would present. So they will present with hemoptysis and hematuria. But it's because it's 2 systems, it helps you define, this disease affects the lung and the kidney. That limits the number of things this could be. And one of them is going to be good pastures. Again, they might then ask you a question about what kind of hypersensitivity is related to it. You will see all kinds of antigen-antibody complex diseases. The paradigm is systemic lupus erythematosus, or SLE, all kinds of vasculitises. And most of the questions that you'll have related to this will have to do with vasculitises. We'll go through some cases, and also with some glomerular diseases. I am not an expert at this. I'll give you some areas so that you can remember that. And type 4 is cell-mediated hypersensitivity, which pretty much covers what we just talked about with cell-mediated immunity, again, with TB and some other diseases related to not only delayed hypersensitivity with CD4 cells, but also direct cell hypersensitivity with CD8s. Again, good old viruses, CD8s. Lots of autoimmune diseases. We'll pick up some more of them. Review them at the beginning. Then, as you go through different organ systems, you'll see them again and review them again. And they all begin to sound alike because they all share a lot of things, all right? There's some kind of failure in thymic or bone marrow deletion of receptors to self-antigen, and that's still well being worked out. Mechanisms are unknown, all right? Generally, examples, classic SLE, and there are certain antibodies and antigens associated with each one of those, which are listed in your handouts. We'll hit a couple of those. Hashimoto's, all right? And Graves' disease in the thyroid, which can present either with hyperfunction or hypofunction. Rheumatoid arthritis, all of this, and you're thinking, I can barely read this. Well, what this means is there's all kinds of antibodies, autoantibodies indeed, an IgM autoantibody to the Fc end of IgG. My gosh, what a complex, okay? But again, the rheumatoid factor is classic. It's not specific at all, but it's certainly a sign that you have to worry about rheumatoid arthritis. But remember, as you're looking at rheumatoid arthritis, this is again antigen to antibody complex formation. But this is not only in the joints where it hurts the most, but also the thing that will kill you is the vasculitis that might affect your lungs also. So you could get somebody with a lot of classic rheumatoid symptoms, but with other symptoms that would help you define this as a vasculitis. Why is this important? Why? Because the disease, the entities, TNF and interleukin-1, that are supposedly now thought to be the mechanisms of injuries in the joints and elsewhere, they're being targeted for therapy. Great question, because that's what's happening now. We're trying to target the mechanisms or the things that are producing the injury. So that would be a good question. Again, back to TNF and interleukin-1. Lots of other examples, all right? Scleroderma, and I've just listed these and they're available for you afterwards, okay? Genetics. 5 minutes worth of genetics, right? Have you had genetics? Some genetics? Any genetics? You will need genetics, okay? What you have in Robbins would be enough, but people in my country who have never taken genetics have a hard time with Robbins, okay? The important thing, which we will not talk about today, there's just limited chromosome anomalies you have to know anything about. Trisomy 12, 13, 18, that's it, okay? And actually, this is not 12. This is a mistake. This is 21, okay? One of the 21, okay? This is the most common one. Well, there will be errors. We'll try to correct it, but if I forget to, it's 21, all right? It's the most common. Great contrast of Klinefelter versus Turner. Great question, okay? Where you will see a lot of the others has to do with trying to define some of the syndromes as well as cancers, all right? When it comes to some of the diseases, a favorite now is triplet repeats of Fragile X and Huntington chorea, all right, as far as the mechanism of injury. How do you remember this? I cannot remember this if I don't use it every day. When you're learning it, grit it out. Not because this is anywhere near all of them, but by putting autosomal dominant, autosomal recessive, S-linked, and most of those are going to be recessive, very few X-linked dominant diseases, all right, that might help you. If you're down in hematology, the fact that hereditary spherocytosis is autosomal dominant and G6PD is X-linked, all right, might be helpful. All right. The nomenclature in neoplasia is one concept that people get confused about. The tumor node metastasis system, the TNM system, having to do with the size and or depth of invasion of the tumor, whether the nodes, regional lymph nodes are involved, or whether there's distant metastasis, is all related for all practical purposes to carcinomas, epithelial tumors, and is the major predictor of prognosis. There's a whole system which we have to use in the United States for that. You need to know that. It's online. You don't need to know a lot of the details. You need to know the concepts, all right? That it is the major predictor of prognosis. Now, you will talk about grading. We won't talk a lot about it today in well, moderately, poorly differentiated tumors. And in some cases, that's important. But staging is always more important than histology predicting patient's outcome, always. All right? Lymphomas and leukemias are very confusing. They have their own system. We'll talk a bit about it, and it may change by the time you take USMLE, all right? Right now, it's based on the WHO system, all right? And it does require you knowing something about the genetics about that, all right? And you're going to have to memorize that, but when you use it, you'll use it every day because people use it every day to make diagnoses and treat patients. So it's not just something you can leave in first year, okay? When you learn about neoplasia, all the cancers, and there'll be a lot of questions about mechanisms of cancer because carcinogenesis is everything. It brings you back to genetics. It brings you back to all kinds of problems in inheritance. It may be, remember if there's a particular associated prior disease, asbestosis, i.e. occupational exposure to asbestos and malignant mesothelioma of the pleura, classic example, lots of others. The genetics, the peculiarities of some of the genetics. If it's not well worked out, don't worry about it. But if it's accepted and it's in Robbins, they might ask you a question about it. Paraneoplastic syndromes, hormone or hormone-like substances, especially in the lung tumors. But there's lots of others that have classic ways they can present that have nothing to do with the tumor itself. Great way to ask questions. Great way to bring in endocrinology. Okay. You need to know something about oncogenes. And I'm not telling you a lot, asking you a lot of questions on oncogenes right now. Why? Because it's hard to separate them out and ask them a question except to throw them in as additional evidence when you're trying to make a choice between two tumors, for instance, because a lot of them are related to a great many tumors. There's one whole group are oncogenes, RAS oncogenes, MYC oncogenes, and specifically some ones that are very particular to a tumor, cyclin D1 for mantle cell lymphoma. Very important one to remember is HER2/neu. It has several names, but with breast, because we measure that to determine whether a woman is going to be treated with Herceptin. So there are some you absolutely have to know cold. HER2/neu is one of them. MYC NMYC oncogene with neuroblastoma is another one. CMYC with Burkitt's is another one. All right? And they will be the italicized, bolded things in Robbins. Tumor suppressor genes, there are many. These guys, retinoblastoma gene and P53 with apoptosis, you have to know everything there is to know about. All right? When it gets down to colon, you need to know the APC beta-catenin pathway. And again, breast related to BRCA1. So most of the breast questions will have to do with Herceptin and also the BRCA1 questions. Translocations with tumors. This is like me saying you have to learn all of the parasites there are to know. All right? You're going, ah! All right? I'll show you some grids, but this is my grid for the most common one, the very first one, Philadelphia chromosome for chronic myelogenous leukemia. You are going to get asked these, and they're related to specifically mostly lymphomas. All right? And we'll just bring them up again, but I'm certainly not going to spend a lot of time because, again, you're going to have to learn it for boards, but mostly related to telling one lymphoma to another, except perhaps for the Ewing sarcoma gene, which is related to a variety of soft tissue lesions. So there's not very many of them you're going to have to memorize, all right? Most of them will relate to the leukemias and the lymphomas. So let's do a couple cases. And 72-year-old man with abnormal radiograph followed by a biopsy, and I'll show you the radiograph and the biopsy. He complains of back pain for the last year and a 5-pound weight loss. And again, as Dr. Strauss, I heard him mentioning several times, I was always making these big and bold. Age is very important, all right? This is probably a little bit better. Can you see this? Yeah? All right, it's a little bit better over here. It's like a punched out osteolytic lesion. All right? Now, if this was a 5-year-old, what would it be? Somebody's saying it. Be brave. One person. Somebody back here? Was it Langerhans or eosinophilic granuloma? Langerhans? Uh-huh. A punched out lesion in the skull in a 5-year-old would be a histiocytosis. It has several names, all right? But this in a 72-year-old. Do you recognize what this cell is? So that you should be able to answer other clinical symptomatology. Hyponatremia, mediastinal mass, because he comes in with this and you have to do other tests, right? Elevated T4 thyroid nodule, elevated hematocrit and red blood cell mass, elevated serum IgG and a positive Bence-Jones protein, elevated PSA or prostate-specific antigen with a prostate nodule. Okay, we ready to vote? There we go. Oh, come on, 21, 25. Go, go. So you recognize the plasma cell? Good enough picture then, okay? Right, but the X-ray itself should have been very helpful because a punched out lesion in somebody's skull has, in that age group, has got to be a metastasis or myeloma. It's classic for myeloma, okay? So this is, what is hyponatremia and a mediastinal mass? Anybody? Why would somebody with a tumor have hyponatremia? That would be an example of what? One of those paraneoplastic syndromes? So if somebody comes in with hyponatremia, Has anybody ever heard of the syndrome of inappropriate ADH secretion? See, endocrinology, right? All right. Now that's associated with some tumors, which we'll get to in a second. Elevated T4 in a thyroid nodule would be a thyroid mass of some kind, okay? And if it's in his brain, it's a cancer. If it's spread to someplace else, it's a cancer. Elevated PSA with a prostate nodule, prostate cancer. That was an easy one, all right? Sneaky one, elevated hematocrit and red blood cell mass. There might be a differential for this. Anybody know? Renal cell carcinoma loves to do that. It's probably not the only one, but if I showed you the right radiograph and the right histology, that would be a good one for this. Okay, so you can see I could change things subtly and ask thousands of questions on this. Let's talk another bony guy. Okay, somebody comes in with this X-ray. And then I do a biopsy. We'll come back to this in a second. Because there's not a whole lot normal. The only normal here, remember on X-rays, you try to do normal with abnormal. Maybe the only normal is down here in the femurs. Okay? Let's go one more. I'm going forward one. Oh, well, both of them. Well, that would be fine on two of them. Okay. And this is bone. So this should be fatty marrow. So now what would be the expected clinical history? 50-pack year smoking history, history of childhood chest and neck radiation for enlarged thymus, recent history of flank pain and hematuria, increased back pain for 2 years and recent onset anemia, or vague abdominal pain with elevated PSA. Why don't we vote? Can we vote? There we are. Okay, there we go. Now, if you got the last one right, you should get this one right. There you go. Okay. Now, we have a D and an E. All right. That's not bad, okay? Looking at, D is not impossible. What is this? This would be a metastatic lung cancer, okay? And that's possible. But I'm going to tell you something about the X-ray in a second that makes that less likely. History of childhood chest and neck radiation for enlarged thymus. It hasn't been done for years, but that puts you at risk for what? Papillary carcinoma of the thyroid, which was, these are the same tumors we talked about before. We just gave them a different history. I'm manipulating the question, which is the lesson I'm trying to teach you with this. Recent history of flank pain and hematuria. Kidney cancer, all right? Now, increased back pain for 2 years and recent onset of anemia is not very specific, but given our previous diagnosis, it goes along with myeloma really well, doesn't it? All right, it's not unique. But now we come down to why this is correct. Let's see if we go forward. These are blastic, increasingly radiodense, incredible numbers of metastasis to the pelvis. All right? They're very classic for prostate cancer. If you see this kind of X-ray, it's prostate cancer until proven otherwise, because osteoblastic bone-forming tumors are characteristic of prostate. Now, this is a tumor in the marrow with holes in it, which means it's an adenocarcinoma, and that could come from many places. It could have come from the lung, but those blastic metastases are more characteristic of prostate. Now, they might give you some more information to make it so that the statistics would look good, okay? Like a PSA or something like that. Or a person who was never a smoker. That would be a good additional history. But can you see how you could, just by this differential, you could ask lots of different questions? Okay. Now, other bony questions are very few. I'm a bone pathologist, all right, but there's very few things outside of metastasis that you'll be asked about on the boards, all right? And that's mostly because of the genetics. We're talking about osteosarcoma in Ewing's. You'll need to know something about that because it's PDs, but because specifically the Ewing sarcoma gene related to peripheral neuroectodermal tumors has a translocation that's very characteristic, all right, and is seen in Ewing sarcoma of the bone or soft tissue. Great question, because remember, there's a whole bunch of like small childhood tumors that are round blue cell tumors, lots of primitive little blue cell tumors that are now distinguished largely by their translocations, as well as hopefully where they come from. A little clinical history still is necessary here. Again, mostly kids, but there's very few other things that are asked about in bone. Now, oh, well, this is interesting. Okay. This is a trichrome. Here it looks blue, and one version of trichrome looks blue. On my slide, it looks green, but it could look either. But this is a trichrome. Does anybody know what trichrome stains? What is the blue and green stain here? That's the key to this question. Now, if you don't know, then this is of heart. Now, this picture, you couldn't tell it was heart. You just know that there's some pink stuff, which could be any tissue at all, and there's lots of this blue and green stuff here. So this is heart. So is this acute bacterial endocarditis? Is this a low power of a myocardial infarction after just one day? Is it 90 days after a myocardial infarction? Could it be subacute endocarditis? Or could it be pericarditis? Now, hopefully, there's some of these that are just really off the wall, but we'll see. Okay, why don't you vote? And the key is whether that blue and green stuff was. Oh, very good. Okay. We have a few outliers here, but it's a bell-shaped curve. Look at that. I'm not going to teach you statistics. That's about what I know about statistics. All righty. But you had to recognize that blue and green stuff as what? Collagen. Okay. It's either blue or green, and it took up a lot of that. So it's got to be an old scar. And you wouldn't expect an old scar in a myocardial infarction after a day. And if this was acute bacterial pneumonia, endocarditis, or subacute endocarditis, or even pericarditis, there'd be a lot more cells, there'd be neutrophils. I would have showed you an abscess. It doesn't, it's myocardium. It's pretty easy. But you had to recognize the blue and the green. That's one of the 2 or 3 special stains you need to know anything about. Okay? Now this is a relatively young MI. Okay, this is an anterior septal defect. And if you have an anterior septal MI, which coronary artery is involved? Anterior. What runs down the front of your heart? Anatomy. The LAD? Left anterior descending, and everybody calls it the LAD. Okay? So you might be asked a question. Which one of these arteries affects that? How old is that, do you think? Now, if that's, it's a pretty crummy picture, it's sort of yellow and weird. But if it's red, you'd expect it to be pretty young, leaky blood vessels. If it's white, you'd expect it to be old and scarred. Okay? So this is pretty red, so it's a pretty young MI. And this is not a great picture. Okay. Now with cardiovascular pathology, and then I just want things that you have to remember, and then we'll take a break. Okay? Just a minute. Okay. In cardiovascular pathology, there's a lot of questions they can ask you. And congenital heart disease, the one thing about it is there's some interesting things. It's easy to remember. Left to right shunts, in other words, ones that are initially give you oxygenated blood, all right, or don't give you oxygenated blood. They're Ds, ASD, VSD, PDA, okay? So that's initially a left to right shunt. The defects, ASD. The right to left shunts all begin with Ts, and the big one you have to remember is tetralogy of flow, all right? Nobody ever asks questions about just plain truncus anymore. It's tetralogy of flow, but it's T's, all right? Coarctation, there's infantile and adult forms. They could ask you a lot of things about atherosclerosis, but it's mostly going to be clinical consequences, things related to LDL, VDRLs, and so forth, rather than anything pathological. Hypertension, lots of things on hypertension, related primarily clinically. All right. Myocardial infarctions at the pathology level, date the gross and microscopic. Lots of neutrophils, red grossly, it's going to be very early. Scar, white grossly, it's going to be late. And you're going to see different trackings of how many days and so forth in different books. Try to keep it as simple as you can, because it's pretty hard to tell a 3 from a 5-day-old. They'll never do that, okay, because nobody'd agree. Importantly, clinically, troponins and CKMB. I'm not sure what you're using here, but these are the prime diagnostic tools in the initial diagnosis of MI. The main reason they come up at just about the same time, at about 4 hours, people argue, but just about the same time. But troponin lasts longer because CKMB is gone within about 72 hours. So that's the main reason. And this is probably going to change, but that's the gospel right now. All right? You'll know the EKG changes. Cardiology went over that this morning. And then the complications. Okay, why don't we stop there? And we'll come back about 5 minutes? Yeah, 5 minutes. All right. And any questions, but either pass them up or just grab me in the 5 minutes we have, okay? Okay, so let's start again. And didn't get any questions, so you know everything. No, obviously we're just hitting high points. And again, there's all kinds of people you can ask questions, but especially if there's discrepancies like trisomy 12, you can always email me and I can make a correction. Okay, let's talk about another cardiac case. And you're going to notice some repetition as we go through, again, because some diseases everybody just loves to ask questions about. So we have a 35-year-old man presents with syncope, found to have some diastolic heart dysfunction with a thickened left ventricular myocardium, an endocardial biopsy. I'm not going to show it to you, but I'll describe. The septum shows myocardial fiber hypertrophy and disarray. The underlying defect in this disease, a gene mutation related to transthyretin, an autosomal dominant mutation in fibrillin 1, an X-linked mutation linked to the dystrophin gene, or an autosomal dominant mutation in the sarcomere gene. Want to vote? Okay. Oh, 2, 4, come on. All right. Okay. This is classic USMLE questions nowadays. They rarely ask, what is this disease? Why? Because they want to remind you that first year was not there for nothing, all right? And because, as time goes on, treatment is being related to these defects. And indeed, to number C, it's already initially underway, even with questionable results. So, let's see. Where do I want to go with this? The simple answer would be one of these 4. Amyloidosis, hypertrophic cardiomyopathy, Marfan syndrome, or muscular dystrophy. So let's go back to our possibilities, being that I'm sure you memorized the other mutations. Which one is related to dystrophin? Muscular dystrophy. And there is treatment now available, at least experimentally, for that. Remember that muscular dystrophy, although it is a debilitating generalized muscular disease, most of the people die of the cardiomyopathy. All right. Autosomal fibrillin 1 is Marfan syndrome. All right. Transthyretin is a new name for B-albumin or prealbumin, and it's one of the types of amyloid. All right. So you need to know those things to be able to answer this question. So that as you go collect information about cardiomyopathies, for instance, you need to say, this piece of material is not trivial. All right, just as Dr. Strauss asked you about whether it's gram-positive or negative or what vectors they use, those things, when you grid out his organisms, you pick out what you think is important that's going to separate one from another. And sometimes you'll be wrong, or sometimes you'll discover there's too much detail, but you have to make those decisions eventually. Okay, so R is down in one of the sarcomere genes. Now there are several things. This is hypertrophic cardiomyopathy. And if there's a classic, already shown a picture of the banana-shaped ventricle of cardiomyopathy, for functional reasons, because it occurs in young people, because it's a genetic disease, it's asked about all the time. Know it cold. All right, it's also interesting, it happens to people of your own peers. All right. When you're looking at cardiovascular myopathies, they can be related to hypertrophic, review the genetics, restrictive, and or dilated. And there's dilated and restrictive have lots of systemic causes, which we won't go through now, that can be helpful, okay? This dilated cardiomyopathy here is usually the end stage, or commonly the end stage, of Coxsackie A or B myocarditis. But it's also the most common variant in alcoholic cardiomyopathy, but not possibly because of alcohol, but possibly because of vitamin deficiencies, okay? So learn the most common ones for dilated, for restrictive, and then the cardiologist can ask you about the functional results of that. Stiff ventricle, floppy ventricle, etc. Valvular disease. People get mixed up between rheumatic fever, acute rheumatic fever, and chronic rheumatic heart disease. This is chronic, the rheumatic fever occurs 3 or 4 weeks, maybe 3 weeks after untreated strep pharyngitis, all right? Not because of a bug, or not because of infection, but because of cross-reacting antibodies. And there's not much more known about it now than there was 35 years ago. But in some of those people, they scar down their mitral valve, most commonly, and go on to chronic rheumatic heart disease. Sometimes then there's all kinds of specifics you need to know about that. But remember that acute rheumatic fever is different than chronic disease, rheumatic heart disease as far as its age and its clinical manifestations. You'll know from the cardiologist about stenosis and insufficiency. When it comes to pathology, they might show you a picture of aortic stenosis, or the classic fish mouth of mitral stenosis, for instance, in rheumatic heart disease. But it's usually going to be secondary to the clinical findings. Infective, non-infective, and SLE-related endocarditis have some characteristics that they all share, but the clinical history will usually tell you the differences between them. Now, remember that the heart has 3 layers: pericardium, myocardium, and endocardium, which includes the valves. So if you hurt one part of that, you usually hit the adjacent structure. So if you have a myocardial infarction, if you have a bacterial myocarditis or a viral myocarditis, you will also possibly affect the epicardium or the endocardium. So there's a lot of diseases that can affect the endocardium. And if you injure the endocardium, you'll get a mural thrombus, which is simply a thrombosis on the wall, mural, all right? And if you, most of the things, if you had a mural thrombus because related to a myocardial infarction, it's going to be in the left ventricle, right? Are you going to expect to get a pulmonary embolism from a mural thrombus in the left ventricle? No, okay? Unless you had a VSD that allowed it to get across the heart. So embolic phenomenon from the heart, remember where they're going. They're going to go mostly systemic, except for some sneaky ones that originate in the right heart. That's a really good question to catch you, all right? And it's very common because there's a lot of things that can hurt the endocardium, not just old rheumatic heart disease. All right. The clinicians will talk to you primarily, and I've already talked to you about dissection and aneurysms, and so that's mostly going to be in the clinical venue, but remember that Marfan syndrome can be associated with aortic dissection and aortic valve disease also. We'll talk now about some vasculitises, great pathology questions, great because they have classic clinical scenarios. Remember, if a disease has a classic clinical scenario, that means there can be very limited diseases in the differential, all right? Tumors, oops, you've already had the most common tumor, the left atrial myxoma. Other tumors are very rare. So now let's talk about a case. 75-year-old woman complains of periodic severe headaches and presents now with sudden loss of vision in her left eye. So you should know what the disease is, but that's not the question, is it? The pattern of injury in her disease is most likely due to fibrinoid vascular wall necrosis, granulomatous vascular wall inflammation, vascular wall abscess, vascular wall infiltration by eosinophils. Okay, let's vote. We are tired or unsure. Well, we have the majority, 44. That's good, because this is tricky if you haven't played this out. All right, 44% of you got it right. It's granulomatous vascular wall inflammation. And why didn't I tell the name? Why? Because the name is temporal arteritis or granulomatous arteritis, so it gives it away, right? It's the most common vasculitis in America, all right? So it's the one you're most apt to actually see, and you do see them routinely. We have temporal artery biopsies looking for this granulomatous. So we see this a lot, all right? Fibrinoid necrosis is more characteristic of another vasculitis. Does anybody know? All right. It's related to polyarteritis nodosa. Now, vascular wall infiltration by eosinophils is sort of non-specific, all right? It's not really, maybe with Wegener's, but not really. It was sort of a throwaway answer, all right? And vascular wall abscesses you can see in thromboangiitis obliterans, people who smoke, their distal, their terminal digits. But it was mostly between these two. Now, vasculitis they're rare but classical clinical scenarios, especially for immune disease, injury, great questions, okay? Also, they have antibody associations. Some are with P. ANCA, some are with C. ANCA, all right? And these are related to myeloperoxidase, perinuclear, anti-nuclear antibodies, and cytoplasmic anti-nuclear antibodies are in the neutrophils, okay? And you need to know these because they affect not only lung disease but also vasculitises. People love to ask questions about them. Okay, another question. We have a 64-year-old man, 30 pack year smoker, and you know how to do pack years, number of packs per year times years smoked, all right? With bilateral apical, partially cavitated lesions, also hemoptysis and a low-grade fever. And I think this one on the left is a little bit better picture for this H&E. This is a hematoxylin and eosin, and this is a special stain which I'll tell you what it is once you've recognized it over here. I think this is the better one for this. This is supposed to be red, okay? This is a big giveaway. Hopefully you'll know this, all right? So your diagnosis in this 64-year-old man: asbestosis, fibrocaseous TB, Goodpasture syndrome, primary carcinoma of the lung, sarcoidosis. Let's vote. You all ought to get this, right? 38, 42, 48, okay, 53. Oh, okay. That's all right, all right. We have 38%, still a good majority of you, all right, got the right answer. This was fibrocaseous TB, and we'll go back. I think I can go backwards to the pictures, all right. And let's go back and do that first. And we'll do it on this, although this is a caseating granuloma. Not a great picture at low power unless you've seen some. Everybody has trouble with granulomas. Go on the web, look up granuloma, look at a bunch of them. They're round pink bodies, all right, made up of cells that when you get higher, and I do have images in the addendum to this to help you deal with this, they're epithelioid histiocytes, which have lots of pink cytoplasm. They're called epithelioid because they look sort of squamous-like, so they almost like epithelial. They have multinucleated giant cells, which you do not have here to help. They have lymphocytes, which you can't see, but they do have central necrosis. This is supposed to be an AFB stain. This is a sneaky question. They would not give you it without telling you what the special stain was on the board. They're not that sneaky. Maybe sneaky, but not this one. So this would be an acid-fast bacillus stain. This, and there's, on your disc, this will look quite good. These are red snappers. These are bright red, little squiggly dotted rods of typical of TB, all right? You really can't tell one TB from another generally, all right? But this is a positive bug stain in a caseating granuloma. That makes this fibrocaseous TB. So the sneaky thing was the smoking. But also the important thing, if you didn't recognize this, is the pattern. So let's go back to the diagnoses. Apical fibrocaseous, cavitating lesions in bilateral apices is characteristic of TB. Whether they showed you an X-ray or described it, very characteristic of TB, possibly histoplasmosis. But a tumor would be one side. It would be one nodule, not both lungs, usually unless it's a metastasis. But bilateral apices are definitely TB until proven otherwise. Asbestosis is a scarring lung disease of the lower lobes, not the upper lobes, with a history that's much different than this, all right? Because history is everything. When they give you an occupational history and age, it means something. They could be sneaky, but most of the time they're trying to lead you somewhere. Goodpasture syndrome, when it shows up as an X-ray abnormality, would look interstitial. You'd be bleeding more diffusely. You would then have hemoptysis. You'd be coughing up blood. To make the syndrome, you'd want kidney disease, hematuria, all right? So you'd be able to say, if I don't have kidney disease, I probably don't have Goodpasture syndrome. Sarcoidosis, young woman, young Afro-American woman with lymph nodes and lung nodules that could be in a variety of patterns, sorry. All right, so different ages, different lung patterns. Lung is all about patterns, all right? All about patterns. If you have a solitary nodule, big differential, mostly infection and tumor, but the other things, the restrictive patterns, the fibrosing lung diseases, often have patterns that will help you, okay? Or they have to give you enough information to lead you to the right thing. How do they do that? They give you pulmonary function tests. Is this obstructive disease, airway disease, like emphysema or chronic bronchitis? Is it a problem with thickening of the alveolar walls so that you're hypoxic, all right, with a restrictive or a fibrosing lung disease? Very much clinical. There are very few biopsies we take of the restrictive diseases that we show on boards. It's mostly clinical. all right? But if you understand the pathophysiology, you'll understand how it got there. Patterns are very helpful. The ones that they might give you pathologically have to do with pneumoconioses. That means inorganic dust disease. In the United States, it's mostly asbestosis and silicosis, well worked out in Robbins or in other medical books. The systemic diseases, Wegener's, good pastures, rheumatoid, lists of them, affect the lung but also affect other organs. Big clue, good pastures, kidney and lung. Wegener's, kidney and lung, as well as upper respiratory tract, the sinuses, for instance, as well as what antibody is associated with Wegener's. C. ANCA, right. So other little hints will take you there, but mostly it's because it's not just a lung disease, it's a systemic disease. Big help when it comes to both lung symptoms and others. So look for the laboratory tests, the other testing to tell you this is not a single organ system disease. Okay. No, the smoking associated diseases. It is mostly COPD, chronic bronchitis and emphysema, but there are a few others patterned into that now. And again, the generalized diseases, we've talked about mostly the restrictive diseases. The rest of them, focal disease, pneumonias and tumors. We've talked about the tumors, paraneoplastic syndromes, etc. And pulmonary function tests can be helpful. Arterial blood gases can be helpful. But a solitary lung nodule may have no abnormalities at all. You've got to wipe out a lot of your lung to have functional changes. All right? Case, 64-year-old man, 30-pack year smoker with right lung mass and enlarged mediastinal nodes. Gross picture, microscopic picture. Again, an H&E. Your diagnosis, adenocarcinoma primary in the lung, large cell undifferentiated carcinoma, metastatic renal cell carcinoma, small cell carcinoma of the lung, squamous cell carcinoma of the lung. Vote, please. All right. Oh, very good. That's a good picture of small cell. And it's not because the cells are so small, it's because they have so little cytoplasm, okay? They actually look a lot like lymphomas. So if you have lots of cytoplasm, it's not a small cell of the lung, all right? Now, renal cell carcinoma looks very different. It's a clear cell. We won't go through all of these, but the main thing that you need to know about, probably histologically, and a lot of people, some of you may have no eye for pictures at all. You may not be visual and have a hard time with slides. So, and there's not a lot of pathology you really need to know. You need to be able to tell a squamous cell cancer from an adenocarcinoma, all right? Why? Because those are the most likely pictures to show you, except for some tumors that have such unique pictures that you would probably recognize them. Because squamous and adeno can be just about anywhere, all right? So you want to recognize those, and these are the 4 main types of lung cancers. Remember, squamous cell, paraneoplastic syndrome, anybody remember what it might be associated with, what it can present with? Thank you. Not uncommonly, small cell is the one that is most apt to have a paraneoplastic syndrome, but squamous, when it does it, likes parathyroid-related hormone, all right, which makes the people come in with hypercalcemia. people with hypercalcemia can come in incidentally, or they can get a little strange in the head, okay? Or can have cardiac abnormalities too. Adenocarcinoma, undifferentiated large cell, which is essentially, you can't tell what it is, but it's a big cell. Small cell loves to be syndrome of inappropriate ADH, which we talked about the hyponatremia before, all right? And also ACTH, so they come in with a Cushing's-like syndrome, all right, which gets back to endocrinology again. The oncogenes, luckily, are not specific for one versus another, but a lot of them have p53 problems. So it's hard for them to be specific about oncogenes in lung cancers. They're still being worked out, but those are the big guys. So if there's discrepancies in oncogenes between, you know, a little bit here, a little bit there, they can't ask you a question on it. Forget it until they decide what's right. You've got better things to do. Okay, here. These are a little bit washed out in here. Let's see here. Oops, there we go. These are cells. This will be better on your disc, I think, but with holes in it. This is an adenocarcinoma. Heaven knows what the background is. All right, but this happened to be in lung. The whole background is just scar tissue, okay? Whoops. Oh, it's yellow. I think it needs a battery too, huh? Well, we've been using it a lot today. All right. Oh, you're just too quick. I hit something? All right. All right. Squamous epithelium is simply trying to look like skin. All right, and these are my pictures of just sheets of cells with lots of pink cytoplasm, and this is trying to keratinize. There are better pictures in lots of places. Be able to recognize it. All right, now sometimes where you are can be helpful because there's some unusual things in the retroperitoneum, for instance, and in the mediastinum. In the retroperitoneum, remember anatomically the kidney, adrenals, ureters live back there. So anything that can go wrong with those lesions can affect the retroperitoneum, but also sarcomas, lymphomas, some germ cell tumors like to live back there, all right? They also have, there's some unusual things that you probably won't be asked about because they're relatively rare, fibromatoses, all right? But that'll help you remember that the abdomen is a different place than the retroperitoneum, all right? And sometimes that affects the spread of disease. Now the mediastinum, most of the times you're going to see are lymphomas, Hodgkin's, and extensions from lung tumors. But we won't go over, I think you can read this vaguely, okay? But we won't spend a lot more time on it. But if you're looking at trying to remember things in the mediastinum, this is a great diagram. All right? Anterior mediastinum, posterior mediastinum. This is the esophagus, heart here. And mostly, middle we'll just ignore for right now, but it's mostly anterior and posterior mediastinum. Most of the action is in the anterior mediastinum, all right? Hodgkin's disease, lymphomas, thymomas, which despite their name are epithelial tumors, all right? Nobody's ever asked me, I have never seen a question on a thymoma in there, but you know, a lot of things. Some of the acute lymphocytic T-cell lymphomas in young adolescents like the anterior mediastinum, all right? So if something says it likes the anterior mediastinum, remember it, because anterior mediastinal mass differentials often are good question follies. Posterior mediastinum, neurogenic tumors. It's the #2 site for neuroblastoma in children, okay? So it's a favorite spot for that. And the anterior mediastinum is the #2 site for germ cell tumors. All right, so the mediastinum, just for sites of tumors, is an interesting spot. Okay, let's do a little GI. Barrett's esophagus. Any questions? Just, all right. Barrett's esophagus is associated with, it should be an increased incidence of adenocarcinoma, gastrointestinal stromal tumor, otherwise known as GIST, marginal zone lymphoma, or squamous cell carcinoma. Why don't you vote? We have, you know, oh, come on. Oh, go, okay. Oh, wow. Ah, see, people vote when they know. You ought to vote when you don't know, because that helps me know what you don't know. Plus, it's anonymous, remember. But you're doing well. So yes, 75% of you knew, because this is a hot topic in the last 10 years. All righty? Good. And I think, yeah, we'll use the same list. So we'll, okay. The tumor associated with c-Myc oncogene mutations and often responsive to the tyrosine kinase inhibitor Gleevec, otherwise known as imatinib, which nobody can pronounce. Same list. Okay, so why don't you vote? See what I've done? I've just changed the stem. Ah, a little bit wider, huh? Well, you knew it wasn't A, okay? Or I could have been really sneaky and it could have been A again, but you're right. All right? The key is actually this gastrointestinal stromal tumor, and the reason to remember that, we do see them not infrequently. But if you remember Gleevec, which targets the stem cell factor CD117 in CML, was found also to be present in this tumor, which can sometimes be aggressive, all right? So it's a great question because of its hang-up with CD34 and CD117 and the associated directed tumor, directed therapy, all right? Great reason for a question to bring you back to basic science. All right. The tumor of the esophagus most closely associated with cigarette smoking and alcohol consumption. Well, we're down to the last 2 or 3 unless I'm being sneaky again, so why don't you vote? Oh, see, the more you know that. There you are, sure, okay. It's got to be squamous, all right. Very good. All right, and we get back to the last one. What is marginal zone lymphoma, maltoma of the stomach associated with? What bug? Helicobacter pylori. Remember, if I couldn't put Helicobacter or talk about the stomach, because Helicobacter pylori is associated with atrophic gastritis, is associated with lymphoproliferative disorder, which is associated with maltomas, okay? So Helicobacter pylori and the stomach is another great source of questions, and David Strauss would love it, okay? Now, in the small intestine, most of what they can ask you is about carcinoid and carcinoid syndrome, or because it's autoimmune, about non-tropical sprue, gluten-sensitive enteropathy, which is very common in the United States because we have many people from Northern Europe. Inflammatory bowel disease, no cold, the difference between ulcerative colitis and Crohn's disease. All right? And there's a few pediatric things you need to know about. For instance, like Meckel's diverticulum, it's 2 feet from the ileocecal valve, all right? And it can present at any age as right lower quadrant pain, for instance, so it's a sneaky diagnosis. Now, colon cancer, great genetics questions, all right? The classic sequence for polyp-related colon cancer is related to the adenocarcinoma polypoid, the APC gene, okay? Beta-catenin sequence, this was all mapped out in the colon. It's one of the best mapped out carcinogenesis syndrome sequences in the body. Know it cold, great diagrams of it in Robbins and other places. If you have a hit for it and are born with a dominant gene, you already have 1 hit, i.e. 1 mutation with hereditary polyposis. If you get another hit, you develop polyps and go on to cancer, all right? But it is still the most common sporadic defect, or the most common genetic defect in sporadic cancers. So in that case, you develop your 2 hits while you're, after you're born. So you develop it later, all right? This is very well worked out. in all of the major Gardner adenomatous polyp syndromes. Don't forget this one. This is a hot new one, not hot, but it's sort of in the books now, so people accept it. People who develop it younger or in inherited non-polyposis syndromes, Lynch syndromes, okay, these people end up more with right-sided lesions than left-sided lesions. They develop it younger, and they may be associated with something called a serrated adenoma, and probably are, okay? That's still being worked out because pathologists are not good at recognizing them, all right? The trick is that they make up about 10 to 15% of the sporadic cases, are inherited in non-polyposis syndrome, and are related to microsatellite instability. Great genetics question. Liver, I'm going to go very briefly through because I think the GI people have probably done this before, all right? Because most of this is clinical. It's a relationship of liver function tests and what you can do with them, okay? And liver function tests, including bilirubin and so forth, can help you tell not only obstructive biliary disease from liver disease, but also alcohol disease from other related diseases. And to me, one of the best ways to study the liver, not necessarily extrabiliary tract, is to center everything about alcohol. Find out what alcohol can do, because that's the major cause of liver disease in the United States, all right, especially cirrhosis. Find out what it can do to the liver, compare other things and find out how they're different, and recognize also that lots of organ systems are involved with alcohol, and knowing what those are, okay, whether it be hemorrhoids or portal hypertension and so forth, can help you define the disease as being centered in the liver. All right. Here's a question. Expected liver histology in alcoholic hepatitis. Steatosis, Mallory bodies, central vein fibrosis. B, extensive granular blue liver cell staining on Prussian blue stain in cirrhosis, one of the other stains you need to know about. Mucin-positive cells with pleomorphic nuclei in multiple nodules in the liver. Ballooning and apoptosis of lobular hepatocytes. Piecemeal necrosis, that's necrosis along the portal tracts at the edges of the lobules with chronic portal inflammation. You need to choose, so I'd like you to vote. This is tricky unless you just know some of the buzzwords, and that's okay. Oh, we have 44 people. Go, 50. Oh, go, wow. Well, we do have a significant minority who have picked the right answer, steatosis. But obviously, liver is tough. All right? If you don't see liver a lot, liver is tough because it all begins to look alike. All right? Here are some good pictures, and there are other pictures on the web. This from the Cornell University site of Mallory bodies. And this is simply actually a sort of a bizarre ubiquitinized keratin, all right, that ends up staining ropey red, and this is just an H&E stain of a liver cell. All of this is steatosis or fatty change. If you know it as fatty change, it's easier than steatosis, but everybody tends to call it steatosis. So fatty change in this, if this is not specific for alcohol, okay, it can be seen in other things. All right, but the central fibrosis, which I don't have a picture of, is very characteristic, the central vein fibrosis. Now, what are the other choices? Well, that granular blue stuff, Prussian blue stains for iron. That would be hemochromatosis. All right? A lot of good questions in there. There are other organs associated with hemochromatosis, genetics associated with hemochromatosis. Great question. Mucin-positive glands, pleomorphic nuclei, cancer. So this is adenocarcinoma. It's got mucin. It could be a cholangio from a bile duct, or it could be a MET, most likely. All right? And if you showed a picture of that or a picture of this, you could just change and manipulate this question. And again, ballooning of hepatocytes, lobular apoptosis, think CD8 T cells, viral hepatitis. Okay? Now, alcoholism, it can be helpful. These are some other things you can look about with liver disease. The clinicians and doctor and nurse and so forth are much better at this than I am, and probably gave you some really great hints. What is helpful pathologically in involving laboratory tests is the AST versus ALT ratio is usually greater than 1.5 to 2 in alcohol-related disease as opposed to viral hepatitis. Now, usually there's history that helps you with that, but that's a helpful thing when looking at the laboratory tests. All kinds of things in the GI. In the pancreas, acute versus chronic pancreatitis. Most of pancreatic cancers are ductal and present as painless jaundice, so it's usually the clinical findings that are related to the pathology in the pancreas, all right? But if you have a bunch of laboratory tests and they're talking lipase and amylase, you're thinking something going on in the pancreas. All right. Now, hematology is best done by the hematologist. That's the reason there's small print, okay? I'm not going to talk about any of those. I'm just going to talk to you about approach to these, lymphomas and Hodgkin's disease. Now, there is a hemolytic anemia related case in the addendum, okay, that I'd worked out that I thought I might use and decided I wasn't smart enough to run it and not be able to answer questions. But it's really nifty as far as the genetics and go. Okay, so why don't you can use that at your, if you're interested in doing that. Leukemias and lymphomas sometimes cross over, so they're being categorized in the same area. They are usually, and they're moving toward complete categorization by translocations and also by cluster designation antigens. In other words, the numbers on their bodies that we can say this particular profile is characteristic of this disease. We still use microscopes, but we use flow cytometry and cytogenetics to define these. And you're going to have to learn some of them. They're used every day. All right, now how do you do that? It's sort of endless. We're going to talk a little bit about the lymphomas, and I'll show you a chart that will help you compare one from another. There are other charts, and this is bastardized from several that I know, okay? Just to compare one from another. Some of them have unique characteristics. For instance, among the B cell lymphomas, hairy cell presents strictly as enlarged spleen. It doesn't have, it's a hairy cell leukemia, but it doesn't usually have a leukemia. It's a big spleen, which groups it into the chronic myelogenous diseases that all have big spleens, all right? So that it's a little bit unique because of that and several other characteristics. So it's a nice one to remember because it's got something that you can say is unique. Hodgkin's disease has just a few things to remember. It's mostly neck and mediastinal masses. Myeloid syndromes, again, are notable primarily because you need to remember the Philadelphia chromosome in CML. And most of these, the chronic myeloproliferative disorders, have big spleens, big help. The leukemias, your hematologist will tell you what you need to know, but they're TDT positive. ALL, the pre-Bs are usually little kids, and the pre-teens are teenagers, anterior mediastinum. Nice clinical scenario, right? Okay. Now, NHL, non-Hodgkin lymphoma, all CD20 positive for all practical purposes. That means they're B cell. The most common one in the United States is small cell lymphoma or chronic lymphocytic leukemia. 70-year-old person comes in with an elevated white cell count. They can present with or develop a lymphoma, so they're categorized in one group, all right? That's the #1 in the United States, followed by follicular lymphoma. They commonly are nodal, spread to the spleen, can get extranodal, bone marrow involvement as time goes on, depending on the regression. They are known now most commonly associated and classified by their translocations. T cells, which I'm just going to briefly touch on, again have a different CD. They're usually CD3 and 5 positive. They encompass part of the anaplastic large cells, but their CD4 leukemias and lymphomas are very unique. The HTLV-associated one mimics Hodgkin's disease, and then mycosis fungoides and Sézary syndrome, which have unique extranodal proliferations and patterns. So the T cells are notable for being extranodal and having weird patterns and associations. It'll help you remember them. And you're looking at this. This is not meant for you to be able to read, okay? It's one of my grids. These are the CDs that are most important, and there's lots more, but the ones that help you differentiate them, these are the abbreviations for the major ones we're talking about. Here, Burkitt's lymphoma, something that's not in here, little African kid, okay? Sometimes seen obviously in other places, but classic clinical scenario. Little African kid, EBV association, also CD10 positive, all of these are CD20, all right? These chronic lymphocytic leukemia in a 70-year-old guy, classically CD5 positive, all right? So some of those CDs are going to be very helpful and very specific. But notice down here, with follicular cell, mantle cell, and Burkitt's, you've got to know the cytogenetics. They're going to ask that. Low power view, I don't think there'll be very many histology that they will show you on lymphomas. They're hard for everybody, and they're not doing this. But this is follicular lymphoma. Can you see the follicles, the nodules? All right? It's mimicking a lymph node. That's the reason it's called follicular lymphoma, but it doesn't have a nice, it sort of merges out with the fat. I just showed you I don't think they'll ever show this to you, but that would be a follicular lymphoma. But this is the starry sky pattern of Burkitt lymphoma. Not unique, but these are dead cells leaving holes as well as macrophages eating up the apoptotic dead cells in this rapidly growing tumor. Starry sky Burkitt's. Now Hodgkin's disease, everything in Hodgkin's is about staging, where it is. Is that on one side of the diaphragm, right and left, one side of the diaphragm or not? Everything is staging. It does have different types. Everybody argues about them, all right? But they all share, or the ones that we still call Hodgkin's, this guy, the Reed-Sternberg cell, owl's eye, binucleate, big, huge nucleus, be able to recognize it. It also shares, in the classic ones, they are CD15 and 30 positive. And I put this up here, people think that it's a variant of B-cell lymphoma. It may never change its name. If that confuses you, forget it for now. Remember Reed-Sternberg and CD1530. The myeloid leukemias have just changed names to protect the innocent. They had a nice system based on their histology from M0 to M7. They have now shifted over to this. Most of them are classified by their chromosome rearrangements, which tend to have better prognoses. That's what you need to remember about that. The ones that are therapy related or after myelodysplasia usually have bad prognoses, and some of them have hour rods. This is a picture of an hour rod. These are myeloblasts, very primitive, maybe a little bit, maybe metamyeloblasts with some hour rods, okay? Classic picture in acute myelogenous leukemia, but they have just changed this. You may be lucky because they've just changed it. Maybe no one will agree on a question, but remember hour rods, acute myelogenous leukemia. All right. The chronic myelogenous disorders, there are too many cells and you have a big spleen. The classic one is chronic myelogenous leukemia. But all of the others can also have a big spleen. What else has a big spleen? Well, a moderately big spleen can be from congestion, like 300 or 400 or 500 grams. When I'm talking big spleens, I'm talking about 1,000, 2,000 milligrams, 1 or 2 kilograms, okay? So those are really huge. In addition to hairy cell, which is our 1B cell that's snuck in here, there are other things that can affect the spleen, but it's mostly the lymphomas, the chronic myelogenous leukemias. Now, if you have a small one, it's been infarcted, and the big infarcting thing is in sickle cell anemia, okay? So little bitty spleen, little bitty kid, Afro-American, Mediterranean background, sickle cell. All right, we have about 5 minutes left. So I'm going to do something. This is there's going to be, there are other things beyond this, obviously, renal and then CNS. You're going to see a lot about CNS and already have with Dr. Norman has already spoken, has he? Reed Norman? Oh, tomorrow, okay. Everything in the CNS is about some degenerative disorders, and I've shown you some pictures of those, and those are well outlined, okay, in books. Number two, when it comes to the tumors in the CNS, sight is everything. Sight and age is everything. And I've given you a list. You need to know what age it occurs in, whether it's benign or malignant, all right, whether it's supratentorial or subtentorial, i.e. in the cerebellum, and where it is. Draw a diagram. Remember the top 5, and you'll get them all, okay? In kidney, kidney is a pain. Kidney is hard to remember. There is actually a very reasonable modification of what I have here in Robbins, okay? And there's lots of grids for glomerulonephritis. They're very hard to remember, all right? But what you need to be able to tell is nephritic versus nephrotic syndrome. And then you can separate most of the glomerulonephritis into 2 groups. There's all kinds of, you know, problems with this, but it's a nice way to begin. If it's nephritic, people have red blood cell casts, hematuria, azotemia, or elevated BUN, and hypertension. And when it gets really bad, they rapidly develop oliguria. That's a rapidly progressive variants of it. All right. Now, in the really worst ones, then you get some proteinuria, then it gets complicated. So forget that for right now. It's this thing, hematuria, red blood cell casts. All right. This is the group. It's post-streptococcal, what do you call it, the glomerulonephritis, and some of SLE, post-streptococcal young kid. Goodpasture's disease, which is here as a syndrome involving the lung, but also a variant of rapidly progressive when it only affects the kidney. Now, what is helpful, the clinical history will usually take you to post-streptococcal or Goodpasture's, but also if somebody wants to show you immunofluorescence, and that would F-L-O, it should be U-O-R, not flower, okay, fluorescence, all right? Remember, it's linear because it's an antibody to a collagen in the basement membrane. So it's a linear pattern, which I have pictures in the addendum for Goodpasture's, as opposed to granular in virtually everything else. So that's a way to remember those. And you can grid it out a different way if you want, but I think that'll help you separate out the details that you think you can remember, all right? Now, IgA, the Berger's syndrome, does a little bit of crossover, but it's mostly nephritic, but it's associated with IgA, okay? Now, nephrotic syndrome, massive proteinuria, which is usually defined as greater than 3.5 grams for 24 hours, hypoalbuminemia, generalized anemia because of the loss of osmotic pressure, all right, and loss of fluid elsewheres, hyperlipidemia and lipiduria. All right, and people usually come in with all of those, or 3 or 4 of those. They are subject to thrombosis. In kids, most of them are minimal change disease. In adults, it can be anything it wants to, okay? And the systemic disorders are the ones that tend to present with nephrotic syndrome. And that, I think, would help you at least remember the peaks. And if you decide kidney's not your thing, you at least wouldn't miss every one of the kidney questions if you remember those things. And here is, again, this is all NS, is all nephrotic syndrome, and this is the grid for that. 2 minutes. Female gyn, you're going to learn about that clinically as far as the clinical findings of pelvic inflammatory disease, which goes into infectious disease. There's all kinds of ways, but most women with symptoms present with bleeding or pelvic pain, which is very nonspecific, right? They have to give you a lot more information. The ones pathologically that you can get hung up on are the tumors, the ovarian tumors. And there's a grid in the addendum for you, but essentially the most common ones are serous or mucinous neoplasms. There are germ cell tumors, which are in many ways just like the germ cell tumors in males, so you can review them together and you don't have to repeat the knowledge. And then the sex cord stromal tumors, which none of us ever see except for this granulosa cell tumor, but they present with estrogen secretion or androgen secretion. So these young or middle or older ladies with granulosa cell tumors present, for instance, with bleeding from endometrial hyperplasia, estrogen-induced. So they have a syndrome. That'll help you remember them. Not that we see them a lot, but they have questions because they have a mechanism that they can question you on. Okay? And I guess to finish, just to finish here, 25-year-old lady with a pelvic mass, otherwise well. Choice of ovarian tumors, a fibroma, granulosa cell tumor, mature teratoma, serous cystadenoma, or a serous tumor of borderline malignant potential. Can we hit that last one as a vote? Can we vote on that last one? Oh, wait a minute. This is on the fly. This one I didn't have. Can you do it in the fly or not? If not, I'm sorry. I forgot I hadn't given you this one. If you can do it in the fly, otherwise we can go down it. Can you set this up to vote? Oh, maybe not. Okay. If not, that's fine. And who knows what this is? What was that stuff? What was that stuff leaking out there? Hair. Okay. So it's not called a dermal. This is a mature teratoma. Okay. Yeah. I showed you that because I didn't have my toothy one. I lost. You can have teeth in them and everything else. And I think a lot of you see those. Okay. Any questions? I'm sure there will be. There's more to finish here. There's also more pictures and so forth and an addendum in some of my grids. I hope it's been helpful. Thank you.
Well, we do have plenty of time. Are there any questions?
Oh, we have 10. Wait, okay, 5 o'clock.
No? Well, then let's take 10 minutes, and then we will close out the session with a how to get a residency position in the U.S. Okay, 10 minutes.